the way I've always looked at panels as being the most useful was kind of how I do it. The how I do it panels are always the best for me in clinical practice and what's relevant. So in the interest of time, I'm going to skip through a few of the kind of basic questions and just jump into the cases. We can talk about all these things. We all know what a cholesteatoma is. We all know our workup as an audiogram and CT temporal bones at minimum. And so we'll go ahead and get into the cases, okay? So the epitympanic cholesteatoma, there's multiple ways to do this. Do you do a canal wall up, canal wall down? Do you do an inside out? Do we do it endoscopic? That's one thing I'll ask the panelists to go over. So I have two epitympanic cholesteatomas, and each one of these were kind of interesting. This 24-year-old med student was referred to me by one of my partners, and he was getting married in 3-4 months. And both the theme between the two of these is they both had something to do really quickly, and they wanted to get it done. So he came in with months of recurrent otalgia otorrhea. You can see his hearing loss there. This is his endoscopic exam. Jimmy, what do you see here? And how would you, let me rephrase that. What do you see, and when you first look in this ear, what are you thinking you're going to have to do, and what do you think is involved?
Okay, so this is the left ear. No, sorry, this is the right ear.
It's the right ear.
Right, yeah, okay. So, I guess just so we're all agreeing here. So, this is the epitympanic area here. This is malleus, right?
No.
Yeah. Okay.
Malleus is right there.
Yep. Got it. Okay. Certainly depends on what the CT scan shows. It looks pretty extensive, as if it's going posteriorly into the antrum and possibly into the mastoid. So Mike knows that.
Here's your CT.
I love the endoscope, but this seems like it might be beyond the endoscope's powers. So obviously there's significant mastoid opacification. We can't confirm that's cholesteatoma, but based on the exam, I have a pretty high suspicion of that. So I would start this case endoscopically, assuming the patient wants surgery. But I would start endoscopically and do as much as I could. But if the cholesteatoma extends posteriorly into the antrum and concerned to be involved in the mastoid air cells, then I would convert to microscope.
Would either of you consider looking at the exam, say this might be something I could do a quick inside out on, or is this definitely going to be a full mastoid?
So look at the audiogram, I would assume that your sicula chain is probably intact. Mm-hmm. Go for that premise. And I would want to know from the CT scan is how big the mastoid is. There's obviously erosion of the scutum. Mm-hmm. So the question is, are you going to land up with obviously an atocotomy, but will you have a Bondi process, i.e. you can skeletonize everything and chase the disease from inside out, keeping as small a cavity as possible. So in those sort of situations, my algorithm, I tend to be a post-oral guy and do from outside in to try and maintain the canal wall. Mm-hmm. But when you've got that degree of erosion, you could try and reconstruct it. Right. But you might want to think about it in 2 stages, depending on what you want to do. But I think the first primary is to get rid of the disease, see what you've got. I'm hoping on that audiogram, it's all lateral, because again, the process is if it's lateral to the ossicular chain, you've got to establish where the disease was. Was that a polyp or in the?
Yeah. That's just a polyp on the exam there.
So it just shows you've got a mucky, smelly ear.
Yeah.
What's his girlfriend's scent smell like?
Must have been terrible. So I ended up going post-auricular. We did a lot of inside-out mastoidectomies with Dr. Backus, and I'll get into my love and hate relationship with the inside out a little bit later. But I opened up the cortex, got it through coronary septum, and this is what I see. You've got a significant amount of cholesteatoma going into the mastoid there. So when you see this, are you considering a canal wall down with a cholesteatoma of this size ever, or are you just seeing what you can do?
Jump in as well. Let's see what I can do is a big thing. I have a hard time justifying a canal wall down if I don't need to.
Yeah.
That's my thoughts. Because then you're left with the sequela of water exposure and all the consequences of that, especially if this is a primary surgery. And especially, I guess it changes if this is not the primary surgery, if it's maybe in my hands multiple times, or sometimes we'll have patients that have had multiple surgeries in other hands, and you're the third or fourth or fifth person in the mix. That may change things as well.
Yeah.
But I think get the disease out. If you have it exposed, the cortex is exposed, you can get in through that. You can go into the adicotomy that's already partial autoadicotomy. Endoscopes are a game changer with that. You may be able to see it from the inside and just do an inside out with an endoscope, and then find an edge and look around the blind pouches. And if the canal wall is not otherwise disrupted except for the scutum, maybe just reconstruct that with conchal cartilage, or leave it exposed, or block the adductus out and just have the kind of the attic exposed. And they tend to do well with that. It's a gravity-dependent area, and just the retracted kind of exteriorized attic alone is not necessarily as morbid as taking down the whole canal wall, in my opinion.
One thing, I've loved to try to do inside out just because I think it's a good challenge, but what I always worry about is the mucosal disease within the mastoid that's still left behind. Are you actually going to improve that? And what are you leaving behind? I don't have endoscopes readily available in my surgical center. We're working on that, but for me, from what I have and what I learned here, the extended facial recess, this guy had involvement of the incus. And so what I ended up doing was separating the incusopedial joint and just rolling the incus out. And then I know then that through the attic and then through the extended facial recess, I can get all the cholesteatoma out. I have a wonderful view, and it allows for good aeration afterwards. So in these patients, when would you consider a second stage for that patient, or would you reconstruct primarily?
Pass it well, or just...
I guess it would depend a little bit on what we knew about the history of he was 24, so obviously pretty young. Kind of knowing how long he'd been having symptoms, if it was kind of a very chronic process or more rapidly progressive. Looks like a lot of cholesteatoma that you had to clean out. So I would also depend a little bit on my confidence that I was able to access all the disease. So if I was concerned there was some more cholesteatoma that was, for example, extending around the labyrinth, or maybe in the sinus tympani, especially it sounds like we don't have endoscopes, and maybe you might be concerned you were leaving some disease somewhere that was difficult to see, and it might be hard to tell even on an MRI because it might be a small pocket. Mm-hmm. So I guess from how it looks and so forth, I typically tell the patients, it kind of depends on when I find the operating room, so I usually tell them between 6 and 12 months. And if it's something really that seems very aggressive and I'm concerned about it might be a place that'll be difficult to get to, and I'll kind of go on the shorter side of that. If I'm pretty confident that we got all the disease and that the areas that I'm concerned about might be where the cholesteatoma, if it does recur, can sort of form a nice, consolidated area, then that might be reasonable to do MRI follow-up and avoid a surgery. So I think it kind of depends a lot on sort of what's been going on with the history and sort of what I find and where my highest suspicion is. So what I think is helpful is if you do the first surgery, be really specific about where you were most concerned that the disease might come back, so that you kind of know, 6 months from now, which of the areas you wanted to pay the most attention to. And if you can see those areas really well, then maybe you're not as concerned. So,
yeah. What are your experiences with the diffusion weight imaging, the non-ocular imaging for cholesteatoma monitoring? Dr. Rule?
Yeah, no, I think we've been fortunate. Matt, again, very good neuroradiologist. So it kind of changed some paradigms with imaging. I agree. If the disease was easy to get out and I'm able to kind of belt and suspenders, if I'm able to drill a layer of bone maybe where the disease was, I used laser with primary cholesteatoma surgery. I'll zap air cells where they were. I think the recidivism rate is very low in those settings. And so obviously you talk about surveillance, but if it's easier to get out, and I've done these multiple layers of treatment where the disease was or where it was tricky, and I can directly visualize it in clinic, I am more likely to watch them and maybe consider an MRI. And I tell them up front, if the MRI is unequivocal, because there's cases like that where they're uncertain or the radiologist kind of waffles around and we say the safest thing in that case then is obviously look.
Yeah, personally, in a metro area with 3 different big health systems, it is a pain in the you-know-what to get them to do the scan and then to actually read it. And I'm not very good myself at reading these scans in particular, so I tend to either just go with my gut and do a second look with a reconstruction. A little more old school, I guess. This guy did actually reconstruct that day, and that was my first post-op audio. He was pleased. He went and got married, went on his honeymoon. He was able to swim. All is well. Second one. This gentleman, his wife is having a baby in 3 months, and he wants to get the surgery done ASAP. He was having a lot of drainage and pain. So this left ear is on the right here, right ear is on the left. How would you approach this? Dr. Hume? Oh, no, I'm sorry. You had the microphone, didn't see that.
So bilateral disease?
No, the left ear, I'm just showing you that the contralateral ear is normal. Sorry, it's not a great picture on the screen there.
So we've got the pars tensor here. Is this a polyp or
No, that's a
cavity?
that's a retraction pocket with cholesteatoma.
Right, that's a massive retraction pocket. I mean, the tegment is probably going to be up here if it's orientated
Yeah,
that way. Yeah. So that's going to land up probably a fairly radical, cavity to start with, and then think about reconstruction.
Chris, can you talk into the mic?
Yeah, sorry. It's a fairly radical. Is that been previous surgery on that?
no,
or
this is primary.
primary surgery. So we've got a lot of attic disease. Just don't think the orientation, the lateral process of the malleus is here,
Correct.
and then this is all disease.
Correct.
So there's no canal, there's no scutum. There's just needs a
The
radical
scutum's
clean out.
completely gone. Yeah,
Do you have
yeah.
any
Yep.
images? Yeah.
Yep.
So you've got a nicely aerated mastoid on the other side. This is a long-standing eustachian tube dysfunction, sclerotic. Can you see? Don't know where the vesicular chain is, depending on the sections.
Not great.
there.
Sorry, my choice in imaging wasn't great. His ossicular chain, the entire heads of the ossicles were completely involved. The malleus was completely eroded. You can see the retraction pocket up top. Good tegment over the top, so no need to get an MRI.
He's got fantastic hearing.
Yeah.
So is the disease acting as the sound transmitter there?
Yeah, and that was one thing that when counseling patients, I will tell them. I told this guy, your hearing's probably going to be worse than it is now, and they have to know that going in, and they're usually okay with it, depending on how much worse it is. So, would you consider an inside-out mastoidectomy on this guy? Do you think that that's going to complete the treatment?
I tend to do post-oral, and it's going to be a modified radical mastoid.
Okay.
And then the debate then is, are you going to obliterate primarily second reconstruction? I think you're going to for stability first and get it clean and stable and see what you've got, and then make your decisions.
Yep, and that's what I always tell patients too. It's Pandora's box when you get in there, and a lot of the decisions are made intraoperatively. So I consent them for a possible canal wall down if I haven't even an inkling of it. But I tell them that my goal is to leave the canal wall up and to reconstruct at the primary surgery.
You have no canal wall there.
Not there. No. So what ended up happening is I don't have intraop pictures on this one, unfortunately. Right canal wall up mastoidectomy with another extended facial recess. Because of the large attic defect and with the extended facial recess, I was able to get everything out. Again, the picture doesn't project very well, but what you're looking at is a big cartilage cap over a prosthesis with a scutal reconstruction here. There's the short process of the malleus there. And I used conscious Simba cartilage through post-auricular incision. Did a Dornhofer style PORP, and that was my hearing result. So kind of for my epitympanic cholesteatomas, I've tried to think about the inside out. I really do try, but the extended facial recess really does a lot for me. And I kind of just expect to sacrifice the incus on most of these patients instead of picking them off. Which brings me to my next slide, the inside out failure. So this is a lady who had a small epitympanic cholesteatoma, and I've got 5 minutes, so I'm going to kind of run through this just for the case of discussion. And this was a great inside-out patient. I spent a lot of time digging that out and doing a nice surgery. She comes back, her hearing's worse. She's got a little bit of pain in the ear, and then she's got this little thing right here. So you can see the inside out there, and this is my ear exam. So how do you consent this patient? What do you talk to them about? Jimmy?
Based on the aeration of the mastoid, I'd certainly consider a canal wall down. If it's a well-pneumatized mastoid, then I would probably just consider, revision inside out.
Which is what I did. Yeah. Pull the cholesteatoma out. There's a view up into the attic. You can see the stapes down here. I had a prosthesis in there that I pulled out and then reconstructed it. So when you're talking about inside out, and really just to kind of talk about scutal reconstruction, what are your guys' key to reconstructing the scutum adequately and making sure that you don't have any recurrence there? Dr. Rule?
The dogma is don't cover something you can't. I guess if you're not sure that you've gotten all the disease out, don't cover it, right? What the nice thing about reconstructing, so let's say you did an inside out and there's a large adicotomy defect, it's gone into the antrum, you kind of have a pseudo canal wall down in that case. Maybe the inferior part of the canal wall is still up. And if you feel like there's a good clean out, you can lay the cartilage reconstruction. Lifting that up on a second look, if you have to go back in, is not the end of the world. You just have to know where the cartilage is. Meaning you don't want to destroy the reconstruction that you've set up. And carefully placing your canal cuts, you can tend to be able to lift that up and look and kind of peekaboo through that window. Whether you do that through the cartilage, whether you do that through a postauricular, a mastoid approach, looking at both. I think that I have no problems as long as I feel like there's a clean resection, putting the cartilage to reconstruct the scutum in this case.
Yeah, you have to take the time, and the palisading is what's really important.
I think good point as well. Making sure they're separate. I think you run the risk, and I've seen some of them where say there's a pars tensa cartilage that's kind of slid up. If it's not separated enough, if it's not locked under the annulus, now that's not going to be a mobile portion, and that can slide up the ear canal because the flap is now large. It has to cover the vascular strip, the tympanomeatal flap, and also the scutal defect. And so you run the risk of it migrating if you don't have them distinct and separate. The palisading cartilage, in my mind.
Do you thin your cartilage to any specific? Oh, sorry.
I used to, and I'm less and less of that.
Same.
Residents can attest to that. I kind of jumped in on the Dornhofer total cartilage tympanoplasty, and I've been impressed with it.
Yeah.
I think that there's a little bit of maybe a wider air bone gap initially, and maybe at the 2 to 3 month mark, but then it tends to go away. But if I'm doing just a palisading like this, and I'm putting a porp or a torp under there, I still tend to thin it out.
Yeah. I've kind of gotten away from it as well, like the 0.5, because then it curls and it's hard to put in a good place. So leaving it a little bit thicker works well. So that's my example. So I think I have to wrap up. I don't know. He's not in here yet, so I'm going to keep going. So this is a 64-year-old autistic male who came to my clinic, kind of patient who comes in with a great family. The guy never complains of pain. He's very pleasant, and he's been seeing an outside ENT for recurrent cerumen impactions, and they just can't get it under control. So I treat him with Lotrazone. It's kind of like my go-to for fungal OE, a really good debridement, and put in Lotrazone, and then see him back in a week. I see him back in a week. I get an audio. This is his right ear is the problem, so he's got pretty decent hearing compared to his left. And I'm cleaning him out, and I'm saying, why is this stuff keeps coming out of the ear canal? And so then I get a CT scan. Here is his defect. Looking at this CT, would either of you even consider trying to rebuild his ear canal? Because I considered it. I was quickly humbled.
Is he cooperative?
Very. Yeah.
I don't know if I would rebuild it completely. I've tried to obliterate the cavity a little bit. And so, I love like endaural canal wall down with bone dust obliteration. The key on this is some people, and you'll find the room splits. People love bone dust, people hate bone dust. The key on this is don't cover where disease was, because then you can potentially create a nightmare. and then now you have an issue with surveillance. And so in this case, if the disease is not filling the mastoid cavity and there's a portion of the mastoid tip or the posterior fossa area that didn't have disease, but now you've opened it all up, it's well pneumatized, I'd consider, if that part was clean, maybe packing, after you drilled and lasered and packed the inferior tip or the posterior fossa area where there was not disease, at least shrinking and bringing that cavity closer to the ear canal.
Do you remove all the mucosa before you put the bone dust in, or do you just, if it's healthy, you just pack it?
I tend to remove it, so bone's on bone, and I packed it dry and put fascia and then a big piece of conchal cartilage to kind of give me a nice smooth shape, and the fascia's on top of that, and then that tends to epithelialize well. But the key is don't cover where disease was.
Yeah, so this is obviously not him. I didn't have an intra-op picture, but huge canal wall defect. He had just a little bit of his scutum by the ear, by the middle ear space that was right. So I ended up doing a canal wall down. When is the canal wall down the right choice? I'd love to hear a couple points outside of your hard indications. What are some patient-specific indications for canal wall downs that you consider? Dr. Hume?
Usually it's previous surgery. I think if you have, I mean, it also depends a little bit on their ability to have follow-up. I think that's a critical issue too. Because there's certainly, at least in my experience, you see canal wall down cavities that are still difficult to maintain, even if you do the best job. Like that guy with a canal wall down cavity, I think I would try to stay pretty hard from having something you had to do, because he's so worried about trapping some squamous debris somewhere. And the pneumatization goes way around his labyrinth out to the apex. So you could really be chasing stuff. So like in reference to that patient specifically, I guess I'd really want to look really carefully at what his endoscopic exam was of his ear and kind of see where the squamous debris is, what's really mucosalized, whether it's possible to block off parts of that mastoid by reconstructing something. Because in some sense, if you are concerned about leaving squamous debris in there, the issue, of course, is this is better hearing ear. But in some ways, if you were concerned about that, you might almost be better off doing a blind sac closure and giving him a Baja or something, just because I think the risks of trapping debris are pretty high based on what you described.
I did a canal wall down on him, and he had such a large matrix that it actually allowed for really fast healing. You know, I save all of that when I'm opening things up, and then I just lay it all down. So there wasn't a lot of the granulation and drainage. And the hearing thing was a tough thing, and I talked to his family about that, and we're considering a Baja moving forward. So anyway, I think that's the end of my talk here. I got a lot more if you guys want to, talk about canal wall downs. You can see Dr. Backus doing meatoplasty. We got all sorts of different things. So anyway, appreciate you guys' time. Any questions for us for the panel?